So thank you very much for the invitation. I'm happy to start this webinar. The project that you have just mentioned is led by Professor Vörös from Zurich and aims to develop a mobile and rapid diagnostic test system for COVID-19 based on a lateral flow assay. This project will provide a highly sensitive means for diagnosing SARS-CoV-2 infection at the point of need. So I will start this webinar with introducing you to the testing strategies for COVID-19. The new coronavirus is causing a worldwide and ongoing pandemic. As of yesterday, more than 25 million infections have been confirmed by WHO, more than 40,000 in Switzerland, and COVID-19 has caused more than 800,000 deaths worldwide. Many healthcare systems were overwhelmed during the first wave in March and April by the sheer number of cases attending hospitals requiring intensive care unit support and mechanical ventilation. And as a consequence, dramatic measures had to be implemented, such as the lockdown. Fortunately, these measures have flattened the curve. After a short break in June and July, we now observe a rising number in cases in many European countries and obviously in Switzerland as well. And this is of concern because we don't know how the future will look like. There are models suggesting that there may be a second wave in autumn or winter coinciding with the influenza season, which obviously would put a big burden on the healthcare systems again. It is clear that now a different strategy is required to mitigate this pandemic, because another lockdown would be devastating for the economy and for the people as well. And so before effective antiviral treatment or a vaccine is available, the only way to mitigate the second wave is to control transmission by using face masks in public, by social distancing, by rapid identification and isolation of cases, and rigorous tracking and isolation of contacts. And the latter two will only be achieved if widespread and easily accessible SARS-CoV-2 testing is available. And this was already realized in March of this year, and I really like the statement from the WHO Director General in March. You cannot fight a fire blindfolded. And we cannot stop this pandemic if we don't know who is infected. And I think this statement nicely underscores the importance, the crucial role of testing in this pandemic. In order to develop an effective testing strategy, it's important to familiarize with the biology, the characteristics of the virus. The virus is transmitted by large droplets and direct contact. And after an incubation period of around 4 to 5 days, people will become symptomatic and will seek medical care. The difference to other respiratory viruses is that the virus itself can be detected already 1 to 3 days before symptom onset and can be transmitted during that time. And with the current testing strategy, this creates a window period where patients are not yet symptomatic, so they will not seek medical care, they will not go and get themselves tested, but they are already able to transmit the virus. And there are now studies suggesting that this pre-symptomatic transmission is responsible for the majority, more than 50% of the transmission worldwide, and that this drives the pandemic. This is an example from a skilled nursing facility where more than 50% of the residents were positive for SARS-CoV-2 already before they showed any symptoms. And this was positive not only by PCR, but by viral culture. So this was really live virus that can be transmitted. And so it's becoming clear that we urgently require extensive testing to identify infected individuals as early as possible before they themselves will seek medical care. So how does the current testing strategy look like? At the moment, symptomatic and asymptomatic individuals, for example, returning travelers or patients of or close contacts from confirmed cases, they will have to go to a centralized test center where they will be swabbed. Afterwards, these swabs will be sent to a centralized testing facility to perform the PCR test. In the meantime, these individuals will either go to the hospital if they are sick, or the majority will just return home, go to work and to school, and wait until they will receive the test result. And here's the major problem at the moment. The time from sampling to notification can take up to 4 days, usually 1 to 3 days. And obviously this is the critical time where the virus can already be spread by these individuals. So the current testing system, the PCR-based tests, have a number of limitations. They require trained personnel, a certified laboratory with expensive equipment. They are slow, they have a limited throughput, there can be a shortage of swabs and cartridges. They're expensive, between 50 and 150 Swiss francs per test, and they require centralized testing facilities. These conventional PCR tests are very sensitive. They pick up the virus very early at very low viral loads, which is great for hospitals where patients can be isolated quickly. But for the community setting, what you actually need is a test that can be repeated, that can detect the virus rapidly, giving you a result in less than an hour, that can be performed at home or at the workplace, that you can repeat daily, and that is cheap. And this then may be an important intervention to transform the epidemic. The role of surveillance testing to control the pandemic is shown here in one of these modeling studies. This is from a modeling study from a college in the United States, where it is shown that one of the most important factors is frequent testing. If you test these students every third day, every second day, then you're able to dramatically reduce the number of COVID-19 infection in this college by a factor of 20. And on the other hand, you can see that sensitivity doesn't matter that much. And the other crucial factor is the turnaround time, so the time from test to report. And this is another modeling study from the United States. On the y-axis, you don't have infections at this time, but infectiousness, so the chances to transmit the virus. This is the current strategy, so testing only when patients are symptomatic. And as you can see here, with this strategy, a number of individuals will caught late or even missed and will have a high infectiousness. If you move to weekly testing or testing every 3 days, then you will increase the number of individuals that are caught early with a low infectious rate. And then please have a look at the time to test reporting, for example, at the 3 daily strategy. If the time to test reporting is 48 hours, this again will increase the number of individuals with a higher infectiousness. So these two factors, frequent testing, rapid turnaround time, are really crucial on a population level. Now, translating these findings to a population level, it becomes clear that an outbreak control strategy largely depends on these two factors, frequency of testing and speed of reporting. So for example, if you're able to test as many individuals as possible every 3 days, you will dramatically reduce the numbers of infections at a given time point compared to symptomatic testing. And this will most likely reduce the burden on the healthcare systems and will mitigate the pandemic, reduce the numbers in many countries worldwide. And now I'm happy to hand over to Professor Vörös, who will talk about this new test that may be used for this purpose in the future. Thank you.
Just checking in case, Janos, you're on mute.
Oh, sorry, I was mute. So hello, everybody.
I just thought you were kind of holding us on tenterhooks, just making us look at the slide. But
Sorry,
you're now off mute. Brilliant, thank you.
I also start my video then. Okay. So do you see me now? Is everything okay?
Yeah, we can hear you, see you, you can crack on.
Perfect. So I will be focusing on the technical aspect of how to develop such a rapid test. What you see here on this picture is the current PCR-based equipment. This is massive, it's highly automated, and it is used in hospital laboratories. You can do up to around 1,000 COVID-19 tests within 8 hours with it. It's extremely sensitive, it has excellent specificity, and it's affordable. We just heard the price is between around 100 Swiss francs at the moment in Switzerland. It is also actually used for measuring all kinds of other diseases. It can detect 2,000 plus all kinds of other disease markers. Typically needs hours to results. Okay. And this is now the solution that we suggest. You also all know this. It's a famous pregnancy test. The technical term is a lateral flow assay, which is a successful example for a home-based in vitro diagnostic solution. You have to put the sample here, and then the sample will go through the matrix, which is a paper-based nitrocellulose membrane. And while doing so, it's actually a highly sophisticated test. It will pick up in an area first, will pick up gold nanoparticles that are equipped with antibodies that capture the analyte. And those antibodies that capture the analyte, along with the particles that are attached to them, they will then bind to the first line, which is functionalized with also with antibodies against another epitope of the analyte. Now, the remaining particles will then be captured on the second line, which is a control line to demonstrate that the test actually works. So 2 lines means that there's a positive test. For example, you are pregnant. Recently, the FDA gave emergency use authorization for such an assay from a company, BD, and there are a few more also now that are available. In order to characterize these tests, we have to know what is sensitivity means. Sensitivity means the number of positives of that are correctly identified of all the positive patients. So all the patients that actually have COVID, how many % we correctly identify as positive. And then the specificity is the true negative rate. This is among the patients who don't have the disease, how many do we identify correctly as negative? This particular test is a point of care system, which means that you have to go to the hospital and you have to do the test there. The nurse will take the sample and then insert the lateral flow assay into this device. But within 15 minutes, it leads to results with a very good sensitivity, about 84% of the positive ones you catch. And what is also nice, all the negative ones will be identified as negative. Now, the 16% that is not captured are probably the ones which are not yet too infectious. And as such, the number of viruses in their samples are below the limit of detection. So I used a couple of terms that I will explain now to you. Every sensor and every test is based on how many analytes we have, and then we get a signal. The more analytes we have, the more signal we get. And at one point, we saturate the sensor. Now, sensitive assays, for example, what is needed for the COVID-19, we all work on this very low analyte concentration regime, where the signal is directly proportional to the analyte that we measure. And typically, we are not really suffering from not having precise enough sensors, but we are suffering from other noise in the system. And this is something called non-specific binding, but you can have also other noise sources. For example, if you look at the optical readout of a lateral flow assay and you focus on these lines, you see by eye that you have these red colors. But what does a camera actually see? Here you see the camera that is capturing the red. You will see such an intensity. You see a tiny dip in the red color in the intensity of the signal. If you look at it in the blue, the dip is bigger, because the reason why we see these particles red is because they absorb light in the blue. So when you have a white light illumination, then they appear red. But this means that when you have no particles present, you still get quite a high intensity signal detected by the camera. And because we have variations between the membranes, we have variation between the camera pictures, we always get some noise on this signal. And this is now directly translated to noise in the absence of the virus on our dose response curve. So even if we have no virus, we do get some variations here, which means that if we start to see now a little signal, we don't believe it until the signal gets higher than 3 times the noise on this 0 signal. And this is what we call the limit of detection. So inherently, systems that have high signal in the beginning will have a larger error and worse limit of detection. So I put it now on a linear scale that you really understand it easily. So although we're measuring something here as well, we don't believe that this is a positive before it will go 3 times the noise at the 0 analyte concentration. And this is what we call the limit of detection. So we can capture only patients that have higher number than that in terms of virus particles per microliter or virus particles that are in the system. So this means that all those patients that are in the beginning of their disease will typically not get captured because their number of virus particles in their system is so low that we don't yet see them as positive. So for a SARS-CoV-2 detection, to make it so rapid, we have to use the similar concept. We have to have gold particles that are functionalized with a detection antibody. And we have to take one of the proteins of the virus, for example, the spike glycoprotein. And we have to have another antibody immobilized to the nitrocellulose fiber to capture the COVID-19 related gold particles. So all the gold particles that carry a spike glycoprotein will then bind to this first line, and we then have to read it out. What is special in our assay that we do this readout differently than the optical readout. The optical readout measures reflectance, contrast, color change, or fluorescence. Another problem with the optical readout that it only measures the top 10 micrometer of the membrane, which means that 90% of the particles do not even contribute to the signal. In addition, paper scatters light and is often autofluorescence, which means that we inherently start with a large background, which results in a high limit of detection. In addition, the readout system, if you don't want to read it by eye, needs LEDs, needs lenses, filters, and good detectors, which bring the price to a certain level, which makes it not truly suitable at home-based detection, only for point of care detection. Our system is based on an electrochemical readout. What we do, we still capture the gold nanoparticles, but then we electrochemically dissolve all the gold, and then we plate it on an electrode, and then we detect it by stripping. The big advantage of this system is that every gold atom that we strip will contribute with 1 electron to our recording signal, and we can then really use all these many gold atoms per particles to get a reasonable signal. And this system requires only very simple electrical components, which means that also the reader device becomes cheap. So if I now compare all the available technologies, the current gold standard, the PCR, is able to detect very low number of viruses, but it's a large machine that you cannot move to where you need it. The speed is slow. You require about a day or more to get to the result. There is serious investment cost for the instrument, and also the price per test is serious. If you now use optical readout for the lateral flow system, you are detecting about 10,000 viruses. The instrument is a desktop-based device. You can get fast results, but the instrument is fairly expensive, so it means that only doctors can afford it, or certain places you can have this device. The lateral flow without a readout is then not sensitive enough to get capture the majority of the patients. It is handheld, it leads to results in 10 minutes, and it's cheap, but still it is not sensitive enough. So what we suggest, this electrochemical lateral flow assay will be able to capture very low number of virus particles. It is handheld, and we will get results in 15 minutes with a reasonable reader price and a reasonable test assay price. And this is why we believe that this is the solution for the rapid testing of COVID-19. I will give back the word now to Michael, who will wrap up and tell you what kind of experiments we are planning.
Thank you very much, Janos. I'll share again my screen. Thank you very much. Obviously, this new test that Professor Vörös just explained needs to be validated against the gold standard. The current gold standard is still the qualitative or quantitative PCR. And so we plan to validate this test in 4 different groups. First, obviously, group 1 is symptomatic patients with confirmed SARS-CoV-2 infection. But then we will also have a negative group and a group with a confirmed infection with another respiratory virus, so for example, influenza or other non-SARS-CoV-2 coronaviruses. And then most importantly, we will also include an asymptomatic individual group. So these are patients that present to our test center here in Basel. As this test should be used at home or at the workplace, we not only will assess samples that are collected by professional healthcare workers, but we also assess samples that are collected by the individuals themselves. So nasal swabs, throat swabs, and even mouth swabs. So in conclusion, SARS-CoV-2 can spread from pre-symptomatic or asymptomatic individual. This is very important to realize and is important for developing an effective testing strategy. Current tests are limited for community detection and outbreak control. And that's why we require novel tests that are mobile, lab independent, sensitive, and with a rapid turnaround time at the point of need. And the electrochemical lateral flow assay is a prominent point of need diagnostic tool, not only for the current pandemic, but also for future epidemics. And hopefully, with the help of these tests, we are able to reduce social distancing, return to a normal life that allows close contacts with family and friends and other individuals. This is a joint project which is led by Professor Vörös, and we have a number of experts in the project team: Alexander Tanno, Yves Blickensdorfer from Hemetron, Vlastimil Gerasko from the ETH Zurich, and then from the clinical side, Dr. Sarah Dreger from my hospital. We are lucky that we are supported by the Botner Research Center for Child Health, by the University Basel, ETH Zurich, University Hospital Basel, and also by Swiss industrial partners. Hemetron, that tries to commercialize electrochemical lateral flow assays, Surface Solution, that is specialized in functionalization of our nitrocellulose membranes, and Complan, that provides help in regulatory affairs. Thank you very much.